So let's move on to NTRK fusions, quite a story for not just lung cancer, but all solid tumor malignancies. A tissue agnostic trial enrolling patients from 4 months all the way into the mid-70s. That would have been unheard of 10 years ago, giving a targeted therapy for patients who harbor these NTRK fusions. Solange, you want to talk a little bit about this data and how it impacts?
Well, it's interesting because when we speak about NTRK, there are 3 NTRK fusions which are usually described, but they might be very different from one to each other, right? So we have some, first of all, diagnostic challenges there. There's a development of antibodies trying to fix on the major ones, in particular in lung cancer, but it's still kind of a unsatisfactory field of diagnostic assessment. So we still have to probably use our techniques of sequencing, even if you might still miss some, right? So it means we have a challenge in diagnosis here. And the NTRK inhibitor, we see here one of these NTRK inhibitors, which, like you said, was tested across disease, across ages. We don't do it so much anymore, right? The BRAF is a good example. You shouldn't do that, but it worked well, right? It looked like that regardless on the disease, lanretinib was working quite well. So I think lung cancer with NTRK alteration might be the next player in this frontline potential TKI administration, but we need some more data, and very importantly, it's not the only drug we have. We will have also at the ESMO meeting the entrectinib data, so there will be other players in this field, but we started a little bit with ALK. We challenged the diagnostic. Remember with ALK, immunohistochemistry, FISH, NGS, with challenging the diagnostic capability we have, and then we will have probably this kind of series of drugs which offer good opportunities, and then we have to be sure that it's better than platinum-based chemo. So all these kind of things. One thing which is important also for NTRK lung cancer, we still have a poor idea or very vague idea of the demographics of these patients. Right? We don't have really this age-defining paradigms, even gender, even smoking is kind of unclear still in this patient. So I think we have to learn quite a lot with registries and real-life data for this patient. It's nice. It's like we're starting the ALK story with something which is new.
It's unique. Very unique. I haven't identified an NTRK fusion yet. We haven't been looking for them, but it is quite a story. I think, again, that'll begin to be told further, and hopefully we'll have more data. But that response rate is quite competitive. Going to be tough to beat. So let's move on to the last gene arrangement, RET fusions. We've had some very promising data presented at ASCO with Loxo drug. Sanjay, you want to talk about the role of this drug specifically for RET fusions?
Yeah, thanks. So, the RET aberrations are another another fusion that we see in lung cancer. Not frequent at all, about 1% prevalence or less depending on the data set that you look at, and are challenging to identify depending on the technology that you use. We know that RET is dysregulated in many cancer types, and since we have a number of RET inhibitors already licensed for thyroid cancer, it makes a lot of sense to pick them from the shelf and try them on our RET patients. But actually, we've been quite disappointed, I would say, with the efficacy we've seen with the traditional RET active drugs, cabozantinib, vandatinib, and there are some of the drugs that we potentially use in day-to-day life which also have RET activity. Alectinib has some RET activity, and nintedanib has some RET activity as well, but not really meaningful responses that we've seen from those, apart from a few case reports. So the introduction of new RET inhibitors designed really to switch off the RET fusion in lung cancer, such as the Loxo drug and the Blue 667 compound, I think are a real game changer for this disease. There's nothing worse than finding a patient who's never smoked, and you've looked through the EGFR and the ALK and the ROS, and then you finally found a RET fusion, you try some toxic another TKI with very modest efficacy. To see this new data, I think, is really quite encouraging, because with both of these compounds we're having a large number of patients with really quite meaningful dramatic responses very early on, with very meaningful PFS as well. So undoubtedly both of these agents will lead to some sort of approval in due course and become hopefully standard for this type of disease.
Anyone used the Luxo drug for RET fusions yet? I mean, we have a patient who I share with Memorial, and I think my clinical experience has mirrored what we saw in the waterfall plots. I mean, dramatic responses with meaningful improvement, which is really, again, moving the bar, not obviously for just the EGFR and ALKs, but these rare mutations where we don't really have much. And this, to me, underscores the importance of comprehensive genomic profiling. We can't just do EGFR and ALK. We really have to look for these other drivers that are actionable with well-tolorated TKIs that potentially could outperform chemotherapy in terms of response rate or PFS. So I look forward to further data with these genotypes and others that may be forthcoming. David, you had?
No, I completely agree. And the challenge is, again, to screen quite quickly this population. If you don't do upfront, generally you never do after. You start chemotherapy, you start immune treatment, and after you don't go back to the tumor tissue biopsy. So that's why I really try to push the oncologist to perform this NGS panel upfront to have the whole picture of the disease and after to have the best adaptation of the treatment. Otherwise, you will miss this patient, particularly for the RET. And I think the most challenging, as you told previously, is for the NTRK population, because we also screen all the patients and we do not find a lung NTRK patient. And probably the incidence is lower than 1%, and it's really a rare disease in non-small cell lung cancer. We know that you can find this type of molecular alteration across probably more than 20 different tumor types, but probably in the lung, it's really a rare alteration. So that's why we need to push further to screen this population.
And we have to be careful that some of our panels or some of our equipments are potentially not completely ideal in, for example, identifying RET fusions too. So we still have to have a critical look at what we really detect and how we could maybe improve it. But it's so rare that it's difficult to make real evidence out of it in a glimpse, right?
Yeah.